Noswaith croeso. Good evening and welcome, everyone. In order to initiate our 2024-25 program of Science and Health Lectures, it's a great pleasure to be able to introduce my colleague, Dr. Elaine Dunlop, this evening. This talk this evening is being held in conjunction with the Wales Gene Park. So Elaine has first-class honours BSc and PhD degrees from Queen's University Belfast. Following the completion of her PhD, Elaine hopped over the Irish Sea to join the Institute of Medical Genetics at Cardiff University in order to commence her research on the rare inherited disease tuberous sclerosis complex, more of which this evening, no doubt. In recognition of her successes in the research domain, a university lectureship resulted in 2019 and a senior lectureship followed earlier this year. Elaine is an academic editor for a number of journals, is an excellent and committed leading on the teaching of genomic medicine, and is also the Division of Cancer and Genetics postgraduate research lead. Diolch yn fawr iawn, Elaine. It's great to have you here this evening. I'd now hand over to you.
Diolch, James. Thank you very much. I'll just try and share my presentation. So hopefully that is showing okay. So it's lovely to speak to you all tonight and to be invited to chat about my research looking at rare diseases. So as James mentioned, I'm going to be talking a little bit about the particular disease that I work on, but also trying to give you a flavour of kind of the wider field and what I feel is important in the world of rare disease research. So I think the first thing we need to get clear is sort of a definition. What do we think of as rare? Because for one person, that and a rare event might be quite common for someone else. So some of the things we might think of, seeing a black swan in the UK. So there are some in the UK, but not very common to see them. So that'd be a fairly rare event for most of us, I would expect. The chances of being struck by lightning, thankfully, fairly low at 1 in 3,000. So also a pretty rare event. But then you have some ultra rare events. So some of these comets that come through our solar system, and this was one from a couple of years ago, estimated to be seen once every 50,000 years. So a pretty rare event, as you can imagine. Something else that's pretty rare is the 29th of February, obviously only coming around every 4 years. And if you were a baby born on that day, the chances would be 1 in 1,461. And because of the rarity of this date in our calendar, it has been designated as Rare Disease Day. So this is really to try and draw some attention to those with rare diseases and the work going on to try and support those patients. So they hold various events around the 29th of February or late February for those years that aren't leap years. And quite often there are events here at the Senedd in Wales. So to put some statistics onto rare diseases, well, firstly, what are we defining as a rare disease? And the EU definition is a disease that affects fewer than 5 in 10,000 of the general population. So basically 1 in 2,000 people or fewer to be classified as a rare disease. Essentially, that means that about 1 in 17 people will have a rare disease diagnosed at some point in their lives. And that translates to about 7% of the population. So for us here in the UK, that is approximately 3.5 million people who will have a diagnosis of a rare condition at some point in their life. There's not a huge amount known about some of these rare conditions, and indeed only about a quarter of the rare diseases that have been identified have a molecular basis defined. So we know the genes or the proteins or the cellular issue that is the problem in these particular conditions. The problem then, obviously, for the other 3/4 is that it's hard to diagnose them and therefore hard to treat them as well. So there are estimated to be about 6,000 rare diseases. I'm sure the number will probably increase as more little bits and pieces get diagnosed along the way. So that's really a substantial number, and no one can be an expert in all of those conditions. With that, in the UK, a single rare disease could affect up to 30,000 people, but still be classified as a rare disease. But the chances are actually most of the rare diseases will affect many fewer people than this. So some might just affect a handful of people or even just one person in the UK. A lot of rare diseases, so around 75%, will affect children and they will be diagnosed early on in childhood. And most of the rare diseases, estimated at about 80%, will have a genetic origin. So that might mean that it's a single gene that goes wrong in these conditions. And there could be a multitude of factors that contribute to the disease development. And there could be some sort of more big chromosomal change in the person's cells, or there could be a few non-genetic reasons. So that's what we're talking about when we talk about rare diseases. Globally, the World Economic Forum estimate that between 400 and 475 million people will live with a rare disease. And for many of those, especially those who maybe are in less developed healthcare systems, they may never actually have a proper diagnosis for their condition. So it's a substantial burden when we look at rare disease as a whole. So for some examples, here are a few on the left-hand side of the screen. Chances are you won't have heard of any of these conditions. They are pretty rare, they're not well known at all. And the one at the bottom, called SWAN, stands for syndrome without a name, because those are the name given to various syndromes where actually there just isn't enough work done, there aren't enough patients being diagnosed to really fully classify those conditions. However, on the right-hand side, these are also rare diseases, but these are ones you're more likely to have heard of. So things like cystic fibrosis, pretty common in the UK and in Celtic populations, things like haemophilia, sickle cell disease, muscular dystrophy, and the familial inherited form of Alzheimer's disease. So these would all be rare enough to be classified as rare diseases, but obviously the general population would know a little bit more about these. They'll have probably come across them at some point. So it shows the kind of range between completely unheard of conditions and ones that actually you will have come across and you will know something about. So what are the challenges for rare disease patients? Well, the first big issue is actually just getting your diagnosis in the first place. If you present to your GP, what's the chances that your GP has actually seen the symptoms of your rare disease before? Hopefully they'll do a good job and be able to, refer you to the right specialists to get some more advice. But the chances are you'll come across a healthcare professional who hasn't seen that particular group of symptoms before and may not be able to give you a very quick diagnosis. And Health Education England estimate that it takes about 5.6 years on average to be diagnosed if you've got a rare condition. And this kind of length of time between, first going to see somebody about your symptoms and then actually getting a diagnosis and a name for the condition is referred to as the diagnostic odyssey. And it's a real challenge for patients with rare diseases. The next challenge, once you've got your diagnosis, is there actually a treatment for that particular condition? And it's estimated that around 95% of rare diseases don't actually have an available treatment. So that's obviously a huge challenge for being able to sort of counsel and guide patients if there aren't sort of well-established treatments for the condition that they're diagnosed with. Then we have the challenges around sort of healthcare bureaucracy and sort of educating doctors. So the healthcare bureaucracy, a lot of these conditions will affect multiple systems within the body. So, one particular specialist might not be the only person you're dealing with. You might be having to juggle several appointments just to get your various aspects of the symptoms dealt with and treated properly. So there can be really quite a burden really on the patient to be able to navigate the healthcare system. And then I've put educating doctors in inverted commas, again, mainly because the doctors you're dealing with may not be very familiar with the condition that you're presenting with. And so quite often the rare disease patients will say that, they have to be their own advocate for the condition. They have to be the one saying, this is what I'm experiencing. This is what I know about the condition. Here's how I think you could help me best. So there is that different dynamic sometimes between the patient and the doctor when they're having to explain a lot of their symptoms. Then, because obviously these conditions are rare, there can be the chance of stigmatization. The public don't understand them very well and can judge people quite harshly sometimes because of the symptoms they're experiencing. And then finally, a big challenge is actually trying to get access to clinical trials. So obviously there are problems with getting treatments to these patients, but if there aren't very many patients with a particular condition, then it's difficult to set up clinical trials. So trying to do a clinical trial with just one patient with one particular condition It's possible there are sort of advances being made to try and do clinical trials in a sort of more clever way to have to avoid the big numbers of patients that they traditionally would involve. But it is still a big challenge for these patients to be able to get access to these trials and new therapies. So why do I think it's really important that we study rare diseases? Well, the first thing clearly is for the patients who are diagnosed and their families, we want to be able to advocate for them and to be able to support them as best we possibly can. So, as I showed you with that list of, some of the rare conditions, the diagnosis might be the first time they've even heard of the condition that they've been diagnosed with. They're going to have lots of questions, and the more research we can do into these conditions, the more answers we can provide for these patients. And that obviously helps alleviate some of the worry that they may have. As well as that, we can, if we know the inheritance patterns of some of these conditions, we can give advice on whether other members of the family might want to be checked for some of these conditions, or indeed if they're thinking of having children themselves or additional children if they've had one child diagnosed, giving them some advice and guidance on the chance of inheritance as well. So that's obviously one of the key reasons that we want to study rare disease. But as well as that, looking at some of these conditions, especially the ones with sort of a single gene change, can give us real insights into the genetics of our healthy cells and how our cells operate and stay healthy, essentially. And then once we know how they work in a healthy manner, we can have a look to see what's going wrong in some of these conditions. The more we know about what's going wrong in the cells, the more chance we have of advancements in treatment for these patients. And the term used quite often in this situation is something called precision medicine. So this is where we know the particular gene or the particular protein or the particular pathway in the cell that's gone wrong in these conditions. And we try and choose our drug or our treatment really carefully to try and counteract that specific change in the cells. And that hopefully, apart from treating the condition well, will avoid a lot of side effects that a less specific treatment might have. And then finally, and as I'll demonstrate with this talk tonight, we have some broader applications of some of the findings that we have from rare disease research, so that the benefits not only to the patients but to the wider population as well. So I'm going to move into the condition that I'm looking at. As James mentioned, it's something called tuberous sclerosis complex, or TSC for short. And it's a multi-system rare disease affecting around 1 in 6,000 patients. And typically the organs that are affected in patients are the brain, the skin, so these little red dots here are these angiofibromas on the skin, the lungs as well, and then the kidneys. And the organs of the body end up with these cysts and benign tumours growing in them. So they aren't cancerous tumours, but they obviously grow and they interfere with the function of the organs themselves. So this is how it might look like if you looked at the patient. So again, you see these kind of bumps, but also these angiofibromas, these kind of skin rashes nearly, a little bit like acne on the face. They get these lung cysts. You can see the little gaps in the scan of the lungs. This aspect, interestingly, predominantly affects women who have TSC. And that in itself is really interesting in terms of the biology behind that and how hormones might be involved in the development of the lung part of the condition. And it's a sort of progressive loss of lung function, which obviously causes huge challenges for the women involved. Then we can have these growths within the brain and epilepsy. And this affects a huge proportion of TSC patients. Around 80% of patients will have epilepsy, and it can be quite tricky to treat as well, the particular type that they get. And then finally, you have these renal cysts and tumours, things like these angiomyolipomas, which are very blood vessel rich and really prone to bleeding, and they have to be watched really carefully to make sure that the patients don't have a big bleed. So those are the sort of standard symptoms that patients might present with. But the range of symptoms can be from really quite mild and, not really maybe diagnosed till even adulthood, to really much more severe symptoms that are diagnosed much, much earlier in childhood. I thought you'd be interested to know that TSC research here in Cardiff has been ongoing for really quite some time. This is Professor Julian Sampson, who kind of spearheaded the early research here at Cardiff, a clinical geneticist. And he and the team here, along with, as you can see from the number of names on these publications, a huge team of people across Europe and the US as well, were involved in identifying the two genes that lead to TSC back in the 1990s. So it's really interesting that we've got the TSC1 gene here, and this one here is called TSC2 on chromosome 16. So how come it doesn't matter which of these genes is mutated? The patient ends up with essentially the same syndrome in the end. And the reason for that is when we look at what these genes do in the body. So this is a little bit of a complicated diagram. I'm not expecting you to follow it all, but essentially here in the middle, we have our TSC1 and TSC2 proteins. So they work together, and it's really important that both bits are working in order to control all this that happens underneath downstream of the signaling. So just to orientate you with this figure, this is your cell surface up at the top. It has lots of receptors, and it's important for trying to know, for your cell to know whether there are growth factors, whether there's glucose, whether there are amino acids, essentially whether they're all the nutrients that the cell can use to grow. And that those compounds send signals down into the cell, and the TSC1 and TSC2 proteins, as you can see, are a bit of a hub for a lot of these signals to come in and to let the cell know, what the nutrient status is. TSC1 and TSC2 act as the brakes then on this system. So if there aren't enough growth factors and things around, they will act as the brakes to stop this particular enzyme called mTOR complex 1 from working. So mTOR complex 1 is involved in cell growth. So involved in making proteins, making more lipids, and making more blood vessels, anything to help cells grow essentially. So normally TSC1 and TSC2 are keeping that in check. They're making sure your cells don't grow when they shouldn't be growing. But the problem then in TSC arises when you have mutations in one or other of these genes or in these proteins, and this doesn't work properly. So this part of the pathway becomes on much more than it should, and you get too much cell growth, and that's what leads to the tumours developing in various organs of the body. So once they had found out what the genes were and what the proteins were and what they did in the cell, the next step was to really try and get some sort of treatment for these patients. So you may recognise these interesting statues. These are from Easter Island in the Pacific. And back about 50 plus years ago, there was a research group went out to Easter Island. They took various samples and analysed them back in the lab. And one of the things they found in a soil sample was this compound here, and it was called rapamycin. So the Rapa bit comes from the name for Easter Island, which is Rapa Nui. So they did a bit of studying on this compound. They found it was quite good as a kind of antibacterial and immune dampener, essentially. And it was used in transplant patients initially to try and prevent organ rejection. But then they found that actually they looked to see what protein in the cell it was interacting with, how it was having its effects. And they found that it interacted with the mTOR protein down here. And actually mTOR stands for mammalian target of rapamycin. So they actually named the protein after the drug that it interacted with. So once they knew that this drug rapamycin was interacting with mTOR, and then they put together obviously the aspect that mTOR is the problem in TSC, it made sense then to try treating these patients with rapamycin so that when the TSC1 and 2 weren't working, you could block the signaling using rapamycin instead. And so this is data from a clinical trial that was led from Cardiff. And you can see that what they did was they measured how big the kidney tumours of the patients were at the start of the treatment, and then they treated them for 2 years. You can see that there's a few patients dropped out along the way. The lines don't quite go all the way along. But generally, you can see there is a decrease in the size of the kidney tumours over time for these patients. So the drug is able to shrink the size of the kidney tumours. So that work, plus clinical studies that were also done elsewhere in other sites in the world, the evidence gathered from all those clinical studies meant that rapamycin, or in the brand name here is everolimus, was approved for these patients to treat their kidney and their brain lesions. So this looks great. We've got a targeted treatment for these patients that's specific for the pathway that's going wrong in their cells. So, why are we still looking at TSC? Why are we still interested in studying this condition? And the reason is kind of best illustrated, I think, from this clinical trial that was run in the United States. And the difference in their trial compared to the Cardiff one was that they gave the treatment for 12 months and then they took the patients off the treatment for the second 12 months. So quite like the Cardiff trial, again, measuring the kidney size of the tumours, you can see very similarly, there's a nice decrease when the patient's on the treatment. But the big problem is if they have to come off treatment for any reason, the tumours grow straight back. Also, you'll see from this that not all patients respond the same way. So some don't respond brilliantly well at all. It takes quite a while for them to get any sort of decrease in the size of their tumours, whereas others are much more sensitive to the treatment and they get a much better response. And we don't fully understand why some patients are responding better than others, given that in theory, they all have the same pathway that's going wrong in their cells. So there's still work to be done on trying to optimize these treatments for patients. And there's a few different ways we can think about doing that. So the first way would be to try and think if there's other drugs that could be combined with rapamycin treatment. So, that might help boost what rapamycin is doing in the cell, might help have a more either longer lasting effect or a more consistent effect across different patients as well. The other thing we can do is have a look at some of the other pathways that are going wrong in these cells. So because I said the mTOR activity is involved in making a lot of protein to encourage the cell to grow, actually trying to process all that protein in a cell that's not expecting to make so much protein can put them under quite a lot of stress. So these cells are in quite a stressed state. And we can potentially take advantage of that with other drugs that would maybe further stress them and actually tip them over to kill off the cells that are causing the problems. So that's another potential way we can go about treating these patients. And the other thing that I'm quite interested in is trying to look at the microenvironment. So those other aspects around the cyst and around the tumours that could be supporting their growth. And so the microenvironment is quite being looked at quite well in more cancerous tumours. So in various different types of cancer, they've looked to see what else is going on to support that tumour growth. And the same sort of thing applies in TSC. So you've got blood vessels coming through your tumours. You've got immune cells, that maybe aren't detecting this as a problem. You've got things like fibroblasts and, all these structures that help support these tumours. And maybe actually by blocking some of these activities, we could actually take away that support for tumour growth and shrink the tumours in that way. So there's a few different ways we could go about improving the treatment options for patients. The other thing in TSC that we're not very good at the moment is being able to sort of give patients a prognosis for what symptoms they might expect. So what we say is that there's a very poor genotype to phenotype correlation in TSC. So when I say genotype, I mean the particular gene mutation that a patient would have, and the phenotype is those symptoms that they would present with. And really, they don't link up very well. So we can't, unfortunately, just look at the particular mutation that a patient has and say, oh, they will have particular kidney symptoms or they will be more prone to the epilepsy symptoms. At the moment, we just can't do that. There isn't a very good link up between the two. So it would be great if we could do better at predicting what symptoms a patient might have and be able to monitor that really closely. And so one of the ways that we can try and do that is from something called biomarkers. So biomarkers are either proteins or DNA or maybe RNA that could be isolated maybe from the blood to be able to be a marker for a particular disease. Equally, you can do imaging. Sometimes that you can do measurements from imaging. That might be a biomarker. Or indeed, with epilepsy symptoms, you can maybe take some brain waves and maybe detect epilepsy earlier. And biomarkers might be considered to be diagnostic. So that would be something that would let you know that the person has a particular condition. They could be prognostic, so they could be helping you work out whether a person is going to be susceptible to a particular symptom. They could help us predict who's going to respond really well to therapy and who's not going to respond so well. Or they could help us monitor the disease. Obviously, TSC is a lifelong condition, and the treatment also needs to be lifelong as well. And so if we can monitor how they're doing on that treatment and whether symptoms are starting to recur at any point, that would also be helpful. So one of the ways I've been trying to do this is to look at some of the blood of TSC patients and look for these little vesicles which are being released by cells. So all our cells release these absolutely tiny little essentially little spheres into their environment, and they end up in the bloodstream. And within these spheres can be protein or DNA or RNA that's come from the cell that they've come from. So the idea is that if you've got a diseased cell, there'll be particular proteins and DNAs and RNAs in here that will be reflective of the fact it's come from a diseased cell compared to a healthy cell. So the starting point for us at the moment is really just, can we distinguish between TSC patients and an unaffected person to find out what markers might be linked to the disease, and then hopefully go on from there to see, well, are any of them particularly linked to some of the symptoms that someone experiences? So we've done a little bit of work on this, and I'm not going to show loads of data tonight, but this is a teeny little bit where we were able to see some proteins in the TSC patient blood that were more highly expressed than they were in the healthy donors. But you can see from this, it's not a nicely clear-cut difference. There are definitely a lot of overlap. And so one protein didn't seem to be enough on its own to be able to kind of make any predictions about whether a patient was affected or not. And we had to combine some of our different proteins together to kind of come up with a scoring system. And that did a better job generally. There's a couple of patients here, outliers, but generally on our scoring system, if you scored a 2 or a 3, it meant you were a TSC patient, whereas a 0 or a 1 meant it was a healthy donor. So this was kind of promising that we might be able to at least start picking out some differences in the TSC patient blood. And our next steps really are to try and validate these changes. That you can see from the number of dots on these, we only had a really small number of patient samples to look at, and we need to check that this holds true for much bigger samples. And then we want to work from this to think about whether any of these markers help us identify what symptoms a patient might be suffering from, and also importantly to see whether we can see any that might respond to rapamycin therapy, so that rather than having to scan their kidneys on a regular basis to see how well they're responding to the therapy, we could maybe just take a blood sample and look for some of these markers instead. So that's where we're hoping to go with our TSC research. So what are the other sort of wider implications of this? Well, obviously, our research and that of others in the field has really tried to pin down what the cellular and molecular changes are in these cells. And there's a lot of work has gone on, especially with some of the groups in the United States, to really work out what's going on with mTOR signaling and all the different proteins that feed into that pathway and alter that pathway. And why that's important is because there's a lot of what are called tumor suppressor proteins. So these ones in red are all sort of part of this pathway. You can see they're all feeding in various places. Here's our TSC1 and TSC2, and here's our mTOR, which is blocked with rapamycin. And the reason it's really interesting to know more about this pathway is because all these ones in red, if they're mutated, lead to other rare diseases. And generally, they've got some sort of tumor development within the condition. So Birt-Hogg-Dubé syndrome leads to, amongst other things, kidney tumors. Neurofibromatosis is sort of nerve sheath tumors. So they all have this overgrowth element to their symptoms. And by bringing them together and understanding more about how this pathway works, we might actually be able to find some common therapies and some common ways to manage these patients. And then looking even more broadly, this is again another version of the mTOR signaling pathway. Here's again your TSC1 and TSC2 to orientate you. This time in red, I've highlighted different parts of the pathway that are found to be mutated or lost in some way in this particular case in lung cancer. But actually in a lot of sporadic cancers, we see overactivation of the mTOR signaling pathway. So that in itself has led to a lot of clinical trials trying rapamycin in cancer as well to see if there's benefit. And you can see here from this table that sometimes it has worked quite nicely. So in some of the kidney cancers, particular types of breast cancer and neuroendocrine tumors, the rapamycin has now been approved as a treatment for these conditions. Some have shown a little bit of benefit, but not enough to be approved for treatment. And actually in some cancers, there hasn't been any clinical benefit seen from rapamycin treatment. But it does show that at least that by understanding more about this pathway and more about the potential treatment options for patients with TSC, actually for other diseases with the same pathway being involved, that means we can roll out some of those treatments there as well. So for the second half of the talk, I was just going to talk a bit more broadly about rare diseases. just to kind of give you a flavour of some of the sort of upcoming studies that are going on and some of the really interesting research that's been done in the wider field. So I have to sort of caveat this that I'm no expert in some of the conditions that I'm going to be covering, but hopefully it'll give you a little bit of a flavour of some of the really important work that's going on. So there have been various sort of reports over the last few years in rare diseases, and the Welsh Government has a strategy as well for rare diseases and genomics. And this is the UK report from the Medical Research Council and the NIHR came out just last year. And they were trying to look and see, how are we doing in terms of funding rare disease research? What might be priorities for the future? And the report that they published covers the 5 years, 2016 to 2021. And when they looked at all the awards that they could kind of search on their databases, around 7% of awards were going to rare diseases. And that was both the total number of awards and the value of the funding that was going from the research. And when they looked into what that funding was going on, they saw that quite a lot of the projects being funded were trying to get a faster diagnosis for patients, which, as I said, is a big challenge at the moment. So it's really important that we can try and do that. And also trying to improve access to care and treatment. Again, it's definitely an area that rare diseases are lagging behind on and need some more investment in. There weren't so many studies being funded looking at, trying to increase the awareness for healthcare professionals and actually to coordinate the care better. And so that is still a real challenge for patients being able to, get the help they need in a coordinated manner from the right specialists. And they also published, the types of diseases that are being funded from the research. You can see that some of them, things like motor neuron disease, Huntington's disease, getting quite a lot of the funding, down to then, some of these other rarer conditions, not getting very much, so many funding awards as the others. So there's quite a range, and you can see even within the rare disease landscape, some are kind of favoured over the others in terms of getting the funding. So what sort of studies are ongoing at the moment? So this is one I thought was really interesting, and it might be of interest to people, and it's called the Generation Study, run by Genomics England. And it's really focused on earlier diagnosis for patients. So you'll probably be aware of the heel prick test that newborn babies get at around sort of 5 days old. It's been ongoing for a long time, and it checks for 9 serious rare conditions that need picked up really early in babies to give them the best chance to be treated and to have the fewest side effects from those conditions. And the idea of the Generation Study is to expand this. So rather than take a heel prick test, they'll be taking a blood sample from the baby. It's usually from the umbilical cord at birth, so that mums and dads would be consented to take part in the study while pregnant, so that the samples can be given straight away when the baby's born. And the cells from that blood sample are then taken, and rather than just testing for a few diseases here, they do whole genome sequencing. So they're sequencing all the DNA in that baby's blood. And from that, they are looking to test for more than 200 rare diseases. So a massive upscaling in how many rare diseases they're checking for compared to the standard blood tests at the moment. And this is from their website. So they're saying that they're going to be testing for diseases that appear in the first few years of life. So, they're not going to be looking for something like Huntington's disease that, comes way later in life. They're looking for things that are diagnosed generally in childhood. They're looking for conditions that can be improved if they're caught early. And as this is an NHS England study, that can be treated through the NHS in England. And those treatments may be relatively simple treatments, or they could be more intensive therapies. And examples of the types of diseases that they're going to look for are things like cystic fibrosis that we've mentioned along the way, more rare conditions that you might not have heard of here, some other blood conditions, things like haemophilia, things affecting the immune system and metabolism. So there's really quite a broad range of conditions that they're looking for. And this is their website down at the bottom if anyone wants more information about it. And actually it made into earlier this month, just a couple of weeks ago, actually, there were a number of news articles about this study. And so they're looking to recruit 100,000 babies for this study to get an idea of whether this is, worth doing and worth rolling out on a broader scale. And it's really interesting. It'll be really interesting to see how this develops and, what results come from this study. The other thing that's rare diseases are really good for is precision medicine. So I mentioned earlier, this is the idea that you choose your treatment based on the specific changes in that diseased cell. So whether it's the gene or the protein or the pathway that's gone wrong. And it's precisely because of these single gene mutations in quite a lot of the rare diseases that make them really good candidates for precision medicine approaches. So this is an example from cystic fibrosis. I'm sure most of you will have heard of it before, so you'll know that it's due to this buildup of mucus within the airways. That's the big problem. And the reason for that buildup is due to mutations in this protein called CFTR. And normally in a cell, this protein is involved in making a little pore, a little channel in the cell membrane, and allowing chloride ions to move freely from the cell. The problem is if you have a mutation in this particular protein and it doesn't form that pore properly, it doesn't let the chloride ions pass through, and that the end result of that is the buildup of thicker mucus that causes all the problems for the patient. So the idea of being able to treat these by trying to target these pores has been around for quite some time. And it was this drug that kind of the breakthrough drug for the condition, because it was developed specifically to treat mutations in the gene that's affected in cystic fibrosis. And the idea was where the pore was normally not doing its job properly, here in the mutated form, the drug could help bind to the pore and allow more of this transport of the ions and alleviate the symptoms for the patient. So initially, the drug was tested and then approved for patients who were 6 years or older and had to have this particular mutation in the CFTR gene. So this was obviously a great breakthrough. It meant that patients had a treatment that was really targeted to the particular problem with their cells. And obviously, as I say, it was approved for therapy. The difficulty with that is that this particular mutation has an incidence of only a maximum of about 5% in the CF patient population. So actually this drug on its own was only going to help a small proportion of CF patients. So after more development, there has now a triple therapy, so 3 different drugs. This is one of them, called Kaftrio, and that is much more effective across a broader range of CFTR mutations. That means more of the CF patient population is able to benefit from this treatment. And what's really interesting as well is there have been some smaller sort of case reports that have shown symptoms, maybe improvement of symptoms in maybe other patient groups as well. So for example, we know that the drug has been shown to improve things like sinusitis and pancreatitis symptoms in the CF patients. And while carriers of one single CFTR mutation don't present with cystic fibrosis because you need 2 problematic copies of the gene to have CF, a carrier with one mutation can still get some symptoms sometimes. So in this case, some pancreatitis. And actually this group were able to show that the same drug could improve those pancreatitis symptoms in a mutation carrier who didn't have the full-blown disease. So I think this is a really good example of where you've got a small population benefiting initially, but then with more development and more work, actually you've been able to bring broader applications to the drug and to the research that has gone on. In a similar way, but with a different mechanism, we can also look at precision medicine in haemophilia. In this case, rather than try and fix the protein once it's made in the cell, they're actually trying to go in and replace the faulty genes in the first place. So if you aren't aware of it, haemophilia B is an inherited bleeding disorder, and basically they don't make enough of a blood clotting factor, factor 9. So they aren't able to stop bleeding as effectively as they should. And then this is the development that has happened in terms of precision medicine and haemophilia. So it's called hemgenics. And basically they take a bit of DNA that has the working copy of the gene. They put it into an adenovirus associated vector. So basically this is a virus, but it doesn't have the sort of viral and sort of properties to make it, a disease in itself. So they put the gene into sort of a virus that's been made safe, essentially, but then they use that virus to get into the liver cells. So they give the virus into the liver cells, and then the gene gets expressed in the liver, and it starts making the factor 9 protein to replace that that's not made by the body naturally. So this was approved in the EU last year, and just this year it's been recommended by the NHS to be used there with NICE approval with something called managed access. So essentially they're still kind of gathering data as they go through this period to decide whether it's going to be a routine drug. Is there enough sort of benefit for patients from it? Big challenge here is accessibility for all patients. So I don't know what the NHS are paying for the drug, but in the US, it has a list price of 3.5 million US dollars, which is substantial. There's also a haemophilia A gene therapy, also recently approved. Again, really expensive, nearly $3 million for that one as well. So just the price alone will mean that some healthcare systems and some private health providers will not be able to fund the treatment. There's also some issues in terms of whether all patients would be suitable for the treatment. So if they've already got antibodies to the blood factor or antibodies to the virus that they're using to get the new gene in, then they're not going to be great candidates. As I say, it goes to the liver. So if they've got liver disease, that's again another issue. And things like HIV infection or obesity could make them not great candidates either. And then because it's a pretty new treatment, there's still some question marks. So we don't know how durable those replacement genes might be. How often might you need to treat someone? Are the genes going to stay there for many years and give it, a long-term durable effect? And the other question, obviously, because it's quite a new treatment, is are there going to be some, side effects from this in the longer term? And until, people have tried this for a longer time, we're not really going to know the answer to those questions just yet. But it's really interesting that they're able to use the viruses in this way to get genes into cells to essentially fix the problem that is there. And it's not just in rare disease that they're thinking about these viral delivery systems. They're being looked at in cancer and various other conditions as well. And then the other really important thing is better connectivity between rare disease researchers and rare disease as a whole. So there is this Rare Disease Research UK, which was launched last year with a big investment from the MRC and NIHR. And it consists of 11 nodes, which have kind of a theme around each of them, and then a hub to kind of coordinate all the activity. And again, they have a website if anyone wants to look up further information on it. What's of interest to me is the fact that there is an mTOR pathway disease node as part of this big funding body. It's being led by King's College in London, and it's trying to bring together 14 different diseases that all have mTOR pathway involvement. And the idea of bringing all these diseases together is to try and improve treatment options for patients who have the same pathway disrupted in their cells. Trying to get a better understanding of the mechanisms behind these diseases and how we, again, might best manage and treat patients. And also to try and improve the diagnosis of these conditions, because for some of them, there is still quite a big diagnostic odyssey. And as part of this node, they're at the moment launching our registry of conditions like TSC and others that are all linked to the mTOR pathway. And the idea of this registry is really to bring together a big bank of data that can help us understand how these conditions are diagnosed and how they're being treated and managed, and how that could be optimized for patient benefit as well. So I'm just going to finish up with what I think is one of the big successes that has involved rare disease research along the way. So back in the 1950s, it was established that there was this correlation between having high cholesterol and having coronary heart disease. That's obviously, a very well-known fact now that, cholesterol is a big risk factor for heart disease. And the reason behind the heart disease mortality was mainly due to this low-density lipoprotein, LDL cholesterol. So obviously, normally you want your blood flowing nice and freely through your arteries. The problem with the LDL is it starts to build up on the artery walls. It impedes the flow through it. It gets a bit sluggish, and you get all the problems that can be associated with that and heart function. So the study of cholesterol and how it all works led to Nobel Prize be given out in 1985. So these are the two scientists who got the Nobel Prize for their work, Michael Brown and Joseph Goldstein. And they discovered that there were receptors on the cell surface that could essentially take this LDL out of the blood and sort of sequester it into the cells and prevent the problems. And that people who had this severe hereditary form of hypercholesterolemia, excuse me, so this rare condition. The reason that they had this rare condition is because they had a lack, either a partial lack or a complete lack of these receptors. So they weren't able to pull in the LDL out of the blood. They had high cholesterol, therefore, in the blood, and then all the risks that come with that. So these two scientists and all the work they did on the pathways and how LDL is controlled in the body, that won them the Nobel Prize for Physiology. So you'll be very aware, I'm sure, of statins as the drug that's used to treat high cholesterol in patients. But actually, the early trials of statins, while they did show that they would reduce the LDL levels in the volunteers, there were toxicity concerns early on. And at that point, there was sort of some uncertainty about whether statins would really make it into the clinic properly. And actually, it was clinical investigators who were working on this rare hypercholesterolemia that was the inherited form that were asking to try statins in their patients because there weren't really any, many other options for these patients. So they had some small studies with this rare condition, and they were able to show some really dramatic reductions in cholesterol levels without very many adverse effects. And then later studies then incorporated both the familial hypercholesterolemia as well as patients with coronary heart disease and non-familial hypercholesterolemia, and again, found good effects. So they kind of were able to roll out the studies into wider patient groups. And as I'm sure you might well be aware with this little diagram here, statins are now basically one of the most widely prescribed drugs in the world. And you can see, especially in the sort of more developed countries, they're massively being prescribed to lower cholesterol levels. So if you think about this being kind of your pathway to get a drug, you start with trying to work out what your gene or protein is that's going wrong. You try and link that to the disease, make sure that is the causative factor. Start trying to design drugs that are going to particularly target that particular problem, put them through preclinical development, clinical trials, and eventually get approval. And in the case of statins, this rare disease, this familial hypercholesterolemia, was kind of involved at various stages of the process, both working out what was going wrong in the cells and then, pushing towards those clinical trials when the future of statins is a little bit uncertain at that time. So just what I hope I've got across to you today is that, our study of rare disease has, much broader implications than just for the patients themselves. So clearly looking at rare diseases and the fact that many of them are genetic gives us really good insight into how our genes should be functioning and interacting in healthy cells, and then give us a better understanding of how that can go wrong. By knowing more about the genetics and the cellular problems, we can then come up with more innovative therapies. So we can think about trying, these gene therapies or these personalized medicine therapies and getting them out into patients. With the challenges around diagnosing rare diseases, obviously, trying to push those boundaries of the diagnostic techniques and the way we go about diagnosing people can be pushed forwards through rare disease research. And then while I haven't mentioned clinical trials hugely tonight, trying to optimize how we can best bring rare disease patients into these trials, considering the smaller numbers of these patients, and using clever designs to do that can be a good way to get more treatments to these rare disease patients, but also design clinical trials more carefully anyway for other disorders as well. Is there still work to do? Undoubtedly so. There are still a lot of challenges with rare diseases, and some, as you saw from the funding chart, are much better supported than others. So trying to get equitable treatment and research into these conditions for all is really important. But I do think that by studying these rare conditions, we can answer the questions for patients, try and uncover new treatments for them, and as well as then roll that out into insights for more common diseases as well. And finally, I didn't show a lot of research tonight, but the little bit I did show was spurred on by Muireann and Jason. And we had help, obviously, from the patient donors who gave us their samples and the biobanks who coordinated that. And then I've received funding for that work from the Tuberous Sclerosis Association here in the UK and the TSC Alliance in the US. So thank you all very much.
Thank you very much indeed, Elaine, for that superb overview that had so many dimensions to it. So I'd now like to open up this evening's presentations to questions from our attendees. So feel free to place your question in the Q&A function that should be at the bottom of your Zoom screen. And we'll hopefully have a few questions coming in for you later. Whilst we're waiting for the questions to come in, if I could just ask you a couple of things that intrigue me, Elaine. So I guess the importance of identifying these rare conditions is it allows the potential for families to connect with other families with the same condition. And I guess that is a really important aspect of inheriting some of these conditions.
Yeah, absolutely. And to put them in contact with sort of specialist support as well. And a lot of the rare conditions will have an associated charity or some sort of network. And so, yeah, that is as much a benefit for even if there aren't very many treatment options, being able to speak to other families and other people affected can really help them.
I'm sure, yeah. And how do we incentivize the pharmaceutical industry then, who are always on the lookout for, the prospect of blockbuster drugs? How do we incentivize them to develop new treatments where potentially, there are going to be limited numbers of patients that can benefit from these treatments? Is this where governments have to come in and provide,
Yeah, so there have been these things called orphan drug status, orphan disease status, where the idea is that it is, yeah, essentially an encouragement from government to, take a look at their drug portfolios, see what, has been maybe proved safe, and maybe it's been through phase 1 trials, it's been proved safe in a patient, and actually maybe some of them could be moved across into the rare disease research field and actually, have beneficial effects for those patients. So it's not necessarily having to completely redesign a brand new drug from scratch, maybe actually repositioning some of these drugs that have been already approved or been through a certain amount of trials could be beneficial for the patients if we can kind of match it up with the biology of the particular condition.
And again, it highlights the importance of having consortia, international collaboration, where each country has a limited number of patients. But if you start pooling those patients, then you can start to make progress.
Yeah, absolutely.
Yeah. Okay, we're looking at some of the questions then. Would you class rheumatoid arthritis and severe sepsis as a rare disease? So again, perhaps you could just clarify for us what is defined as a rare disease and.
Yeah, so a rare disease would be anything that affects fewer than 1 in 2,000 patients. So I mean, I'm not a clinician, so I don't know the stats on those particular two conditions, but my guess would be, I'm sure rare sepsis is, or severe sepsis is a pretty rare condition. So I suspect it probably would come under that. Rheumatoid arthritis, certainly, I would have thought certainly juvenile arthritis and things that come on early, I would expect would be classified as rare. So yeah, I suspect they probably would come under the rare disease banner, but I would have to double check.
Okay, thanks, Elaine. How long does it take to go from a gene protein identification to achieving drug approval?
Yeah, very good question. The answer is a long time, usually. So we are obviously much better now at identifying the genes with whole genome sequencing, whole exome sequencing. That bit of it is much faster than it used to be when they used to have to, take big family studies and really try and pinpoint down on the chromosomes where the genes were. So that bit has sped up a lot. Trying to work out what they do in cells sometimes I think is easier than others. It helps if it's a single gene disorder, so you're only looking at one particular protein that's going wrong. Obviously, some of the conditions affect, bigger parts of the chromosome, and they're much harder to kind of pin down exactly which bits are causing which symptoms. Then the drug approval process usually takes years, maybe decades. So actually, if you have to go from scratch and design your drug from scratch, that in itself is going to take a long time. You're then going to have to test it in cells in the lab, maybe some animal models, and those preclinical checks. Then you'll need to go into healthy volunteers and make sure it's not too toxic for people to take. And then eventually you might be able to get it into the patients that you're actually interested in helping in the later stage trials. And then you've got to gather enough data from those trials to convince the regulators that this is safe enough to give to patients. So yeah, in itself, that usually takes, maybe a couple of decades potentially. And obviously anything we can do to speed that up. I think sort of the ways that we can look at some drug design now with sort of AI and sort of the docking that you can do between the protein you're interested in and the drugs, those kind of things hopefully will start to cut the time down as well. And obviously the smarter we can be with the clinical trials, that might help get things through that stage as well more quickly, but it still does take a long time.
Okay, thanks, Elaine. Why do patient factors such as ethnicity, sex, and age impact how rare diseases are diagnosed and approached?
Yeah, so I suspect this is probably an under-researched aspect of it. Certainly the UK population and the patient samples I've generally been working with TSC have predominantly been from a white background. Trying to, encourage other groups to, contribute to these studies and making sure that they're included and involved in the studies is really important. Um, so yeah, I think it's probably under-researched exactly, how well we're doing and making sure that everyone is getting to benefit from the research and from the treatments. So yeah, I suspect there's more work to do on that area, even just getting the data behind it. Obviously with TSC, we know that the lung aspects are predominantly a female aspect. So that in itself is interesting and trying to pinpoint why that particular manifestation seems to be so much more hormone sensitive. But then we're hoping obviously that the treatments, if they target the mTOR pathway, would benefit both males and females with the condition because it's the same pathway underneath it. That's the problem. But yeah, I suspect that's something we could do better at making sure we're addressing.
Okay, thank you again. Um, Perhaps you could tell us a little bit more about some of the ethical issues of using these experimental drugs. Are these drugs initially tested on animals?
Yeah, so our lab in particular, we don't do any animal research, but yes, essentially drugs generally are tested on animals at some point in their process. Because obviously, it'd be very ethically difficult to say, well, we're going to put these straight into a human without, with only having tested them in cell lines. There is definitely a move to the sort of what's called the 3 Rs, so reducing and improving our animal studies so that there aren't as many animals having to be involved in these studies. But at the moment, they are pretty much a sort of an essential way to try and check how these drugs are metabolized by a whole body and how safe they might be. There's still no, it's not a guarantee that just because they're safe putting them in a mouse that they're going to be safe in a human. But at the moment, it's kind of the best option we've got for an extra check on how safe they might be.
Hmm. Thanks again. Is there any research being done on the prevalence of rare disease in rural areas or third world countries?
Ooh, very good question. I'm not aware of any, but then I'm not aware of the full spectrum of what research is ongoing in the field. It is, as I said, there's over 6,000 rare diseases, so I don't know exactly what's going on everywhere. I suspect, however, a bit like the sort of ethnicity and sex angles, that we're probably not doing a very good job of making sure that we reach everyone who could benefit, especially in sort of some of the maybe there's other healthcare systems where they're maybe don't have the same funding, don't have the same outreach capacity that the NHS might have. So yeah, that's something we could probably do better at as well as a rare disease community.
And presumably some of these conditions are a combination of environmental factors as well as the underlying genetics, and then they only maybe manifest in certain parts of the world. Is that correct?
Yeah, I would expect so. I don't know, I can't give any specific examples, but yeah, there is a multifactorial element to some of these. So yeah, you need the environmental exposure or whatever it might be to develop the condition to start with. So yeah, it may be more prevalent some places than others as well. Certainly, and I suppose some of the conditions like cystic fibrosis, which is much more prevalent in sort of a Celtic population, essentially because that's where the mutations are kind of hiding in the population. And I guess you see this sort of similar things with haemophilia or sickle cell disease. There's certain populations are more susceptible to those because of their underlying genetics. And so, yeah, it's important, I guess, to look and see where the hotspots are for some of these and to make sure you are reaching those particular patient populations.
Excellent. Are some of the rare diseases life-threatening? I think that's.
Yes, yeah. A lot of the ones that are picked up in childhood can be very life-limiting. So yeah, absolutely. Unfortunately, that is the case for some of them. Yeah.
And for patients with SWAN, which I think is syndromes without a name, isn't
Yeah.
it? Do they get treated since the disease is unknown?
Yeah, I suspect, I mean, again, not clinically trained, but I suspect you could probably treat their symptoms to some extent. So, I guess depending exactly how they're presenting, it may be that it's a condition that has epilepsy as part of it, and maybe you can use a standard epilepsy drug to try and reduce that. So I suspect they do try and manage the symptoms they present with, but there wouldn't be a targeted therapy because they don't know exactly what is actually wrong in the cells to specifically try and target that particular problem.
And Elaine, going back to the new generation study, so you're
Yeah.
screening a newborn, you identify a change in the genome of that newborn, How do you then know that that change is what's actually implicated in possibly causing the disease as opposed to, being
Yeah.
relevant?
So I haven't looked at the full list of diseases they're looking at, but I suspect they've been picked because there are fairly well-defined databases of mutations so that people who have already been diagnosed with, for example, cystic fibrosis, they know the range of mutations that are pathogenic, that are causing the disease, compared to maybe other mutations that might not actually cause any problems. So they'll be able to compare the DNA sequence that they take from the babies, firstly to the sort of standardized sequence and find out where the changes are. And then subsequently from those changes, they would then compare to some of the databases to say, well, has this been reported before? Is this a known disease causing mutation? In which case you're going to be pretty confident in going back to the parents and saying,
Right. Yeah.
yes, unfortunately, this, they do have the mutation. The tricky bit is, and it's the same with not just this study, but any study that looks at the whole genome, you might find mutations that you don't have enough evidence for either way. And that has a bit of an ethical dilemma. Do you report that back because it might be nothing? Or, do you hang on and see? And generally, those unknown significance sort of changes wouldn't be reported at the moment, but it may be that actually if more evidence comes to light in the future, then you would be able to relook at someone's data and say, oh, yeah, actually that has now been shown to be linked to the disease and we can give you a definite diagnosis based on that.
Right. How do we get results out to practitioners such as oncologists? And does the generation study that analyzes baby blood for the 200 conditions that you mentioned feed the results back to parents about the potential risks to children?
Yeah, I'm
To their
pretty sure
children?
that the generation study is feeding back. So if there was a mutation identified, I think that's fed back fairly quickly to the parents. So, obviously they can try and get some sort of treatment in place as soon as possible. I think if there aren't any changes, it maybe takes a few more weeks because obviously they're less worried about getting that result back to the parents. But I believe that they're trying to keep all the parents who consent to the study informed of the outcome for their child.
It
And
was
sort of the other
about
one.
dissemination to practitioners as well,
Oh,
like
yeah. So I guess it depends what aspect the question relates to. So if it's a patient coming in getting sort of a genetic test on their tumor to choose a treatment that might suit them best, that would all go through the NHS side of things. So that would go through All Wales Medical Genetics Service to do the genetic screening, and then they have their systems to get that back to the oncologists. In terms of the kind of research we do, our preclinical stuff would be hopefully published in scientific journals and published at conferences. So we would try and disseminate to the scientific community and the clinical community that way. In my case, there's a TSC clinic at Cardiff. So I've contacts with the two clinicians who are involved in that clinic. So if we found something particularly interesting that we thought was worth trying to get a study set up with patient involvement, then we would go to them. And I think that's probably the same for most of the cancer scientists at Cardiff. They usually have either clinicians within their department as well, already, or they have clinicians that they can go to and speak to about their findings.
Thank you again, Elaine. Some children can't be diagnosed during their childhood. How do you manage to prevent them from those rare diseases once they're grown up? Are there other diagnosis processes that could be done for these rare diseases in for adults? So, um,
Sorry, just rereading the question to make sure I've got it right.
so was that a
Oh, so
reference to
essentially is
how?
that if you miss the diagnosis in childhood, then how do you go about diagnosing them later on? Is that the gist of that question, I think? So yeah, I
I
mean,
think so.
obviously, if the person had fairly mild symptoms, they might not get picked up particularly early in childhood. And certainly there are some TSC patients who are only really detected in adulthood. So I guess it's usually done on symptoms. If you're presenting to your GP with a particular set of symptoms, maybe your parents haven't taken you when you're young, you've just kind of got on with it, and maybe actually it's bothered you enough when you've been an adult to go and get it checked out and try and get a diagnosis for it. So yeah, I guess it's the same way that, any symptoms would be dealt with in terms of going to your GP and trying to get them explored a little bit more.
Thank you, Elaine. I'm conscious of our time running out, so I'm just going to finish up with one more question, Elaine.
Mhm.
Are there any specific university courses? Because I suspect that some of our attendees this evening are thinking of pursuing these fields. So, are there any specific university courses to study rare disease, genetics, either at Cardiff or other universities? Um, and would you potentially learn about rare diseases if you were doing pharmacy or
Yeah,
pharmacology?
so there won't be any, I don't think there's any specific rare disease only courses, but definitely a genetics course and potentially a biochemistry course, I say a pharmacy course, a medical course. Any of those would have some element of rare disease within them. Um, and if you do a medical course, you might choose to do an intercalated course, so a BSc within that medical course where you could specialize in, say, genetics and get a little bit more of a flavor of rare disease within that. I know certainly the medical course at Cardiff, they do a little, quite a short sort of rare disease week module to let students get a bit more of a flavor for it. And certainly, if you were to do a sort of more general science course or genetics course, when you think about your sort of final year project, you could try and find someone who could help you do a rare disease based project as part of that. So while it might not be a core component of the course, you could probably mold it a little bit to suit your interests as well with the projects.
Indeed. Elaine, I'd first like to thank our attendees this evening for their active involvement and some really excellent questions. Apologies for any questions that we haven't managed to get to this evening. Um, and it also remains for me to thank you, Elaine, for a really superb presentation, such clear slides, such uh, beautifully presented as well. So we're very much in debt to you for that evening.
No,
We
thank you for
appreciate
the invite. I enjoyed it.
We will be in touch with we will be emailing our attendees to ask for their feedback for this evening's presentation. So watch out for that email. And we are back again next month. We have Dr. David Miles from the London School of Hygiene and Tropical Medicine, who's going to be talking about vaccines, particularly whooping cough vaccines, a century of good science and bad. Some of you might be aware that we have had outbreaks of whooping cough in the UK in recent years. So many thanks again to everyone, and have enjoyable rest of your evening. Thank you now, and thanks again to you, Elaine.
Thank you.
Good night. No
Bye.
stop.